All right, good afternoon, everyone. I'd like to introduce our grand round speaker, Dr. Despina Kontos, who had a long and very storied career at the University of Pennsylvania, but has just recently taken on a new role as the head of research, basically, Vice Chair of AI and Data Science Research in the Department of Radiology at Columbia, where she is Professor of Biomedical Informatics, Biomedical Engineering, and Radiology. Dr. Kontos is an expert in radiomics, the expert, one of the absolute top experts in the US, and especially radiomics as it pertains to cancer. So, Dr. Kontos.
Thank you very much. Thank you for the kind of introduction. It's a pleasure to be here. I remember I was here again many years ago, maybe as a very junior faculty, something like that, a long time ago. And it's really exciting and a great pleasure to be here with you in your esteemed department, seeing so many great colleagues and friends over the years. And so I recently moved to Columbia University there, wearing a few different hats, and I'll give you a little bit of an insight as well during my talk about some of the initiatives we're doing here, and hope to be able to build new bridges and collaborate with more of you here at home. So I'll give a rather broad overview of the work we do in my research lab. I figure we have a blend of different people with different levels of expertise, some very strong sort of computationally savvy faculty members here as well, but also trainees, clinicians. And so my talk is going to be a little bit relatively broad, give an overview of the type of work we do in my lab. I'll draw a lot of examples from breast imaging, as it's an area, breast cancer, that I've worked in for many years now. But these paradigms can be also applicable to other types of cancers, especially solid cancers. And I'll give some examples perhaps for some of the other recent areas we're moving into: lung cancer, ovarian cancer, pancreatic cancer, and so forth. And then, I'm happy also to take questions. And I know I'm spending a lot of time in the afternoon with the computational groups here, so that will be an opportunity to dive deeper in methodologies as well. So part of what we do in our lab is to develop image analysis, pattern recognition, data mining methodology to investigate the role of imaging as a biomarker for personalized clinical decisions in cancer care. Personally, I've always been split a little bit between engineering and medical school. I always had a natural tendency in engineering, but I always kind of wanted to be a medical doctor. It didn't end up happening for several reasons, primarily because I didn't want to stay in school forever. And here we are, still in school. But I've always been also drawn very much from hypothesis-driven research. And so I would say about 40% of the work that we do in my lab is really develop novel computational approaches and methods to analyze imaging data. Another 20% more recently is to investigate methodologies that allow us to integrate information from imaging data and non-imaging data, including electronic medical health record data, molecular profiling markers, genetics, pathology, digital pathology, and so forth. And another 40% of the work that we do is purely hypothesis-driven. So taking these tools and try to put them either in large epidemiologic studies, retrospective studies, prospective studies, clinical trials, and try to determine if they're actually helpful, especially in the context of driving clinical decision-making in cancer care. So when I think about cancer care, I think about three different areas. So screening and prevention, prognostic assessment, and therapy treatment. And also a big kind of backbone of what we do is not necessarily to diagnose. We leave that to our very capable experts, the radiologists, but we're looking really at predicting at what happened in the future. So necessarily telling you what's going on right now, but what will happen in the future. And develop these models that integrate multi-omic biomarker information in a predictive context for cancer. So in the screening and prevention setting, for example, we want to be able to identify which individuals may be at high risk and may need more frequent or more intensive screening recommendations. We also want to identify which individuals are at lower risk and may not benefit from more intensive screening. We also want to think about risk-reducing interventions, and we may want to think about guidelines around screening protocols and also even behavioral interventions, for example, in smoking, in cancer, in lung cancer. In the prognostic setting, once you're diagnosed, we want to know how aggressive the disease? So what's the likelihood to benefit from different therapies? What mutations may it harbor? And an area that's of great interest is characterizing tumor heterogeneity, which is a very important, increasingly recognized phenomenon in cancer that has implications for therapy response and developing of resistance. And finally, in the course of therapy, we want to be able to predict which individuals are going to do better under different types of therapies. We want to also be able to identify early in the course of therapy individuals who are not going to do well with a specific therapy, because we do not want to deplete their immune system. We don't want to exhaust their, ability to undertake a different type of therapy that may be more beneficial. And this is becoming increasingly important in the current era of targeted therapies and immunotherapies, and having so many different options of therapies and combination therapies, that it's important to be able to recognize early on who will not benefit and who could be eligible for a different type of therapy. So again, giving some examples from the area of breast cancer, in the area of screening and prevention, a lot of the work we've done in our group and others is to develop computational methodologies to characterize patterns and characteristics of the normal breast tissue, or at least the presumed normal breast tissue, that may be predisposing to a higher risk of developing breast cancer. And this is an area that we sort of work with radiomics over time, and perhaps one of the most established areas we do in the group, trying to identify phenotypes of the normal breast tissue that may be indicative of the risk of developing breast cancer, and then use that information to try to guide personalized screening recommendations and risk-reducing interventions. And this is an area that work has been going on for a very long time. And when I say very long time, I mean a very, very long time, since the 70s, where John Wolfe at the time was one of the first who empirically observed from zero mammography, which was the modality of choice at the time, that women who had more complex breast parenchymal patterns were at a high risk of developing breast cancer. And he was kind of questioned a lot by his peers. Nobody truly really believed him. But here we are now, more than 30 years or more, getting into more than 30 years now of John Wolfe's research, that we recognize this epidemiologically. We still don't have a good biological mechanistic understanding of why this is the case. And that is another area of great interest. But for example, we now understand that mammographic density, which is the amount of fibroglandular tissue in the breast, tends to appear right in a mammogram, as an important risk for breast cancer, both as an independent risk factor. So you have higher mammographic density, you're more likely to get breast cancer, but also it can reduce the sensitivity and specificity of screening mammography. And that has, in the last several years, has come into the news a lot because it's become a federal law to report mammographic density during screening and use that information to ideally guide personalized screening recommendations, even though the guidelines are still very kind of coarse, debatable, not very specific, and so forth. So there's a lot of debate right now around breast density. How should we measure it? How should we report it? How should we use it? How to define personalized screening and so forth. And this is an area of great interest. So a lot of work that we've done is to develop fully automated methods, first of all, to measure breast density, to move beyond the subjective qualitative evaluation, either in the Bio-Rad's four-categorical Bio-Rad scale, which is still very subjective. If you do, there are many studies comparing differences in radiologist assessment of breast density, but also moving from the conventional paradigm of mammographic density, looking at other three-dimensional modalities, including breast MRI, digital breast tomosynthesis, whole breast ultrasound, and also moving beyond just the conventional binary assessment of breast density. As I said earlier, breast density refers to the sort of bright areas of the tissue in a mammogram as seen clinically. This is the dense tissue and has been associated, the amount of the dense tissue, with increased risk of breast cancer and reduced sensitivity of mammography. And so going beyond this kind of percent amount of dense tissue by measurement, characterizing the overall distribution and the pattern of the dense tissue, looking at radiomic approaches, and now more recently also in AI and deep learning approaches, which in some sense takes us back to that notion of breast complexity that John Wolfe originally observed. And I'll show you an example that I think further affirms that we should not underestimate human intelligence when we're talking about artificial intelligence. So here's an example of 4 different mammograms. The one on the left, if you were just going by clinical criteria for breast density, they are both considered like, both are considered like to be highly dense breasts. But you can also see that the distribution and the pattern of the dense tissue is very different. One is more distributed, and the other one is more kind of centralized and smoother in some sense. But again, going back into that notion of complexity. And then you can see the other 2 breasts on the right-hand side that would both be assessed as kind of low density. But you can see that even the one of them really has some kind of like pattern in it and some level of complexity versus the other breast seems to have less of that pattern present. So again, I'm starting to think about that notion of breast complexity is different than the binary assessment of breast density that we were used to in several of the epidemiologic and clinical studies. And perhaps breast density came to be the easiest surrogate of breast complexity to measure, just because, several years ago, we only had film mammograms to begin with, right? So that was easier to measure from a film. And even when mammograms started becoming digital, it was the easiest thing to measure in terms of like segmentation, thresholding of the image, and so on. Let's do better this day and age. So I'm sure I'm probably preaching to the choir when I'm talking about radiomics here. Again, another term that has more relatively recently came into the spotlight, but really in its concept is not as recent as one would imagine. In fact, it kind of goes back to the same time of John Wolfe and some of the features proposed by Haralick and others in other domains, even including military application, satellite imagery, and so forth. And sometimes I kind of joke a little bit about it, saying like, radiomics came to be when radiology realized that we also had to have something that ended with omics to be able to remain relevant, right? So, but radiomics really refers to the extraction and analysis of large amounts of advanced quantitative imaging features with high throughput from medical images. And what has happened here is what has happened in several other domains, including sort of RNA sequencing and profiling, that we now have the technology, the hardware that allows us to extract these features in a computationally tracked way. So it's actually possible to do that versus, a decade ago, we weren't able to do that as easily, especially for high dimensional imaging modalities. So what do these features refer to? They can capture all kinds of different properties. So when we're looking at tumors, for example, they can capture morphology, such as the size, the circularity, the irregularity, the margin sharpness, histogram characteristics. They can capture if we have, let's say, dynamic modalities, such as dynamic contrast enhanced MRI or dynamic PET, kinetic characteristics. So peak enhancement, time to peak, wash-in slope, washout rate, and so forth, which give them some information about the contrast agent uptake. And we know that has to do sometimes with angiogenesis or other metabolic properties of the tumor. Can also capture characteristics with respect to the heterogeneity of the tissue, both the heterogeneity of the normal parenchyma, but also the heterogeneity of the tumors, which I'm going to go in more detail into as being an important sort of prognostic and predictive indicator. So it can capture aspects of the homogeneity, variance, entropy, and other types of characteristics in the image. And then we have also a lot of sort of more higher level descriptors, including the wavelength transformation, the Fourier transform, the fractal dimension, that capture properties of, let's say, self-similarity at different resolutions and properties that are more difficult to assess with just the human vision. So I'll show you an example of how we extract those features, for example, from the digital mammogram. And it's kind of simplified here, but it helps understand the notion. So for example, in a mammogram, one way we can do this is we can sort of overlay a virtual lattice on the image, the area of the image interested. And then at every intersection of the lattice points, we can look at a region of interest and extract those measurements. And you can think about this region of interest becoming as big as the entire image or as small as an individual pixel. And of course, that has implications with respect to computational cost and how long it takes you to do the analysis. And our group and others have done several studies to try to optimize, find a sweet spot where you can get information that's nuanced enough, but doesn't become equivalent to noise. So if you go very, very low in resolution, you start capturing noise, which is not ideal. If you go very, very, very coarse in resolution, you basically start getting that more kind of coarse information that density provides in the first place. And you may not be able to get additional information for the parenchymal pattern diagnosis. And again, a little bit of background information, and I promise this is actually the only equation slide I have in the presentation, just to give a little bit of a sense for our clinical trainees of how what these measurements capture. So for example, a very simple measurement is skewness. Those are moments of the gray level histogram. Think about an image as a two-dimensional matrix of numbers, or a three-dimensional matrix of number, or four-dimensional. And basically you can look at these gray level values, for example, in a mammogram and see if the histogram is skewed in one or another direction. What do we care about that? Say, well, for example, in the mammographic context, a histogram that's skewed to the left is shown to associate with dense regions of interest, a more kind of high-risk type tissue. And if you're looking at a fatty region of interest, at a more kind of low-risk type of tissue, the histogram tends to be more skewed to the right. For example, then we have a little bit more complicated kind of measurements, parallel type of measurements. For example, coarseness and other characteristics utilize a sliding window that go around this neighborhood and try to see how much the gray level values differ from each other, right? So the more difference you have, you might get more fine texture in the image. The less, the more coarse texture in the image. This again, then we're going to be like a little bit more complex in type of information. We can look at the frequencies by which gray level values appear next to each other, right? So when you have similar gray level values that appear next to each other, then you have, for example, less contrast in an image. But when you have more dissimilar gray level values appearing more frequently next to each other, you have more high contrast in the image. And then I won't even go there with those equations. As I said, measurements such as fractal dimension and others capture self-similarity at different scales. They have been shown in a whole, breadth of applications that can be very useful. For example, this self-similarity is thought to be a natural property of tissues and other structures. Think of coastlines, think of like the structures of a leaf, that kind of self-similarity pattern. Look at your own fingerprints, right? So when this self-similarity is disrupted in the pattern of the tissue, it could be an indication that some kind of abnormal process is happening that could be predisposing to a higher risk. And by the way, feel free to ask any questions if you have. We can, you don't have to wait all the way to the end. And so that, by applying all these features and think about it from this very kind of simply presented definitions, you can extract hundreds or thousands of features with different parameterizations, different definitions. And what really this does is takes us from the original digital image space to a higher dimensional image pattern space. And then there's a lot of questions we can ask, and a lot of methodologies we can think of developing on how do we parameterize this information, how do we use these feature maps. You can see, for example, the feature map from the entropy image and homogeneity image. How do we use this information to make some useful kind of decision, right? So, for example, how do we use this information as an input to a risk assessment model for breast cancer? We can parameterize it, we can apply some more sophisticated tools, we can even now put them as inputs to a deep learning model and do all kinds of different ways of analysis. And so I'll pause here for a second and I'll ask a question. When you see this kind of heat map, what's the first thing that comes into your mind? Question for the trainees.
RNA-seq.
Right? I mean, for me too, when I say this, first thing that comes to my mind, RNA-seq. But as I was saying before, what has happened with the radiomics sort of feature extraction, kind of in principle with like RNA sequencing analysis and so forth, this is actually a heat map that is not constructed by RNA sequencing or genomic data. This is a heat map that is constructed by radiomic data. So in the same way we can use RNA sequencing information to characterize sort of the molecular makeup of a tissue, of a tumor, and so forth, we can use imaging signatures and radiomic information to extract phenotypes of the disease. So how does are there any similarities in the way that the tissue, the normal tissue here, or cancers later, I will show you, appear in radiologic imaging? And if that's the case, what does this mean biologically? What's the interpretation, and how do we use information normally? I tend to like this approach because you can extract hundreds of features, or even thousands, and then do something like this and get down to like 2, 3, 4 categories that can actually be very powerful. And that's what happens with molecular profiling as well. Of course, there are many other approaches, computational, we can think about, but I tend to like this because it also has some visual interpretation, especially when it comes to heterogeneity. So here, when we're talking about the complexity of the breast parenchyma, we're looking at the heterogeneity of the normal tissue. Is that related to the risk of breast cancer? This was a preliminary study we did with about 2,000, a relatively smaller sample of women. Every column represents a woman. Every row represents a feature after some kind of feature reduction methods. So we took 2,000 women, we took all their mammograms, those were regular screeners. We took left and right breast, CC and MLO view. We extracted these radiomic features, hundreds of them. Then we applied some statistics, removed some noise, we used the dimensionality, came to a feature set that seemed to have the most information. And then we applied this unsupervised hierarchical clustering that is basically agnostic to outcomes, looks at the data, and tries to combine this information in a way that groups most similar measurements together and separates most dissimilar measurements. And the way we coded the measurements were, the more red you see, it means the more heterogeneous structures, and the more green you see means less heterogeneous. So here you can see you have like 4 distinct statistically significant groups. We call them phenotypes, we call them clusters, right? One that has lower heterogeneity, low to medium heterogeneity, medium to high heterogeneity, and very high heterogeneity of the normal tissue. And then we started looking at, okay, before we look at outcomes, who gets cancer or anything like that, let's look at how does it relate to other characteristics. Does this phenotypes reflect age? Does this phenotypes reflect conventional percent density? Does it reflect body mass index? Does it reflect, a callbacks? What is and what do we care? And somebody tell me, why do we care? And first of all, looking at how these groups, how these phenotypes correlate with known information. I know it's tough after lunch. I know. That's why I ask the questions. So basically, if we're gonna do all this sophisticated stuff, right? And if we're gonna take this information and put it in a risk model, ideally we want to make sure we're capturing some kind of new information. If this information is merely a surrogate of like conventional percentage or like age or BMI, I'm always a fan of simple is better, right? So if we already have this information, who cares, right? So first we have to answer the question of why do we care about this? And then how we can do it better or more sophisticated or whatever else we want to do. So the first thing we did was basically see, does this information, is it the same as breast density? Because if it's the same, then who cares? We get that in the radiology report, we're done, right? So here you can see how these phenotypes correspond to percent quantitative density. And what we saw was interesting and kind of goes back to that notion of the figures I've shown, right? So what we saw was that there were cases that had very high percent density, but low parenchymal complexity. Which cases are these? Well, maybe those are the ones that are totally dense, right? There's all white, nothing else. There's no pattern, right? But there were also cases that had low density, but very high complexity, right? So first indication, there is some association, but it's not a linear association. There's information that's definitely not one-to-one sort of correspondence. So that's good. That means it's worth start thinking more about this, right? You don't want to kind of take it to the highest level of your effort, resources, analysis, whatever you're going to do, just to find out you already have that information in a much more simple manner, right? That's the first thing you always should ask. So what? And what do I care about, getting more complicated? Again, and then we can start putting numbers to that notion of complexity, right? We average the measurements. I mean, first we Z-score them, standardize them, so they could all be on the same reference. And then we starting averaging them and come up with what we call the complexity score. So now you start putting some numbers to that notion of complexity, which is good. We want numbers because that's how models work. So percent density relatively similar, but complexity almost completely opposite. That kind of makes sense with respect to what we're looking at. Percent density again low, complexity completely opposite. Low complexity versus high complexity, low complexity versus high complexity. So instead we start getting some additional information. Okay, that's good. Then we say, all right, before we go and start writing grants with like 4 or 5 sites and try to get resources and funding to really kind of make a new model for the general population, can we actually see this information that appears to be different, has anything to do with predicting who's going to get breast cancer? Because if it doesn't, and then who cares? Right. So again, this was one of the preliminary studies we did where we took a very small case control sample, about 76 cancer cases and 158 controls, extracted these measurements, these radiomic phenotypes, and then looked at how that information relates to the ultimate cancer diagnosis. And not only looking at that, but accounting for percent density and see if the information from the phenotype still remains important. That's the second important, because if that doesn't help me here, then I don't need to go. And so what we saw here was, obviously percent density was important and had statistical significance, but the information from the phenotypes, the radiomics analysis, also retained significance quite a bit, even after we accounted for percent density. Oh, that is helpful. Now I can go and say, well, now I'm going to scale this and see if I can make a model that can ultimately be applicable to the general population. So then we took this information, we wrote a grant between, at the time, University of Pennsylvania, Mayo Clinic, and UCSF, and we proposed to do a study with 45,000 women, basically collect all mammograms we had at all these sites with sufficient ethnic representation of African American and Asian women. That's another very important thing to be thinking about. And see, first of all, if this notion of kind of phenotypes can be replicated, can we reproducibly see phenotypes? And again, larger sample, we may have the ability to refine these phenotypes and go deeper. And then see if we can also see these associations with cancer in a much larger sample. So we had more than 40,000 women here. This was presented as an oral presentation in the San Antonio Breast Cancer Symposium, and currently is under revision by a major radiology journal to be published hopefully soon, where we saw that we could replicate this notion of phenotypes in a larger sample. And also, now we took a completely independent sample from 3 institutions with 1,082 cancer cases and 2,837 controls matched on certain criteria, and representing different ethnicities as well. We were able to see that the association also was independently strong with breast cancer, and most importantly, for 2 scenarios, for Black women and for what we call interval cancers. So interval cancers are the cancers that are diagnosed in between regular screening intervals and could be either cancers that were, mammographically occult on the screening visit, or very small and they were somehow missed, or cancers that were very aggressive and grew in between. It's kind of hard to distinguish between the two and clearly know what it is. But we saw that was most of the value of these phenotypes. So these are all, exciting new directions. And then again, artificial intelligence also has a major role to play here. The conventional sort of convolutional neural networks, in many ways, what they do is extract these radiomic features at even larger scale, as filters at the different convolution layers, and then synthesize them at multiple resolutions to make even more use of the data. So this is another area we're actively looking right now, how to combine these features with CNNs and how to feed the original scans versus the radiomic scans, and of course going from 2 dimensions to 3 dimensions and digital breast tomosynthesis, which is a modality that is increasingly replacing mammography. Yes.
So you may have touched on this point, but when you have an instance of we've now turn the clock back.
Yeah.
So there are features that you could really allow us to answer.
So that's what we did. We started with the cancer definitions, and then we went back and look at the earliest negative mammograms. So we were able to predict we'd get, not to detect. Like we made sure we were at least, a year and a half before. So we were looking at a predictive test.
Even though those earlier screen scans on radiograph.
They were negative. Yes, we were able to do that. Yeah. What we're working on right now is basically to adapt this to lung cancer screening. In many ways, lung cancer screening is where breast screening was like 30 years ago or something. The recommendation of who should be getting screened are very, very coarse. You have to be basically a very heavy smoker. otherwise you don't qualify. And we know that, lung cancer also gets detected to, individuals who are not very, very heavy smokers, increasingly so. And also, we want to be able to identify individuals who are at high risk especially because screening is targeted towards very heavy smokers. It could be a good opportunity to initiate smoking cessation conversations. If you can have some evidence that says, look, you're at high risk of developing lung cancer, maybe you want to rethink smoking here. So the interesting thing about a lot of these computational approaches is that they're not tied to any specific modality, right? So we're working on adapting these methodologies from two-dimensional mammography to low-dose CT. We've done some studies trying to see if we can characterize the lung parenchyma. The idea here is kind of similar to the notion of breast density, that they are patterns of the presumably normal lung parenchymal tissue, such as, pre-clinical manifested COPD, inflammation, interstitial lung diseases, and other characteristics that may be predisposing to lung cancer. And then see if we can incorporate that information ultimately into lung cancer risk assessment models. Like the problem here, of course, is that lung cancer screening is not as widely available or even as widely adopted, so much smaller data sets, much more difficult to do this. But this is an example of where we can take an approach of one setting and then take it and translate it and apply it to a different setting. So again, in this context of lung cancer screening, we've done similar approaches for low-dose CT, looking at the complexity of the normal parenchyma, looking at radiomic approaches to capture that complexity, trying to identify different phenotypes, and try to understand what they mean, if they reflect, for example, smoking, if they reflect BMI, age, if they are associated with lung cancer. We recently had a publication on this, a feasibility study showing that we indeed identify phenotypes, at least in a small data set. We can account for this in acquisition, because CT acquisition is even more variable than mammographic acquisition and perhaps more difficult a little bit to standardize. But we've shown that we have methods that we account for those variabilities. We can still recover some signal. There seems to be some preliminary evidence that we can sort of utilize this approach for something similar in lung cancers, risk assessment, which is an area that we're very interested in working. This whole topic could be a completely, different talk, and also it has kind of, I think, it's given rise to several PhD dissertations. It's a question we always get when you think about the how reliable are these features, how reproducible are these features, and there's a lot of debate in the field. For many years we were all trying to really control the scanners and make sure all the scanners are the same, which will never happen in my view. And we can still have some general guiding principles which are good, and some generalized guidelines. But we also need to recognize that will never be the case, that technology always evolves. Individual physicians have different preferences of how they want to acquire the scans. So there will always be some variability. In my view, that's necessarily a bad thing, because that is real world data. And we need to be developing methods that are sort of able to be robust in some level of noise. And similar with the kind of signatures we're trying to uncover, if they're so nuanced that some noise can completely obscure them, then probably they won't be valuable for any kind of population level decision, right? If they're so weak that some noise in the machines can completely dominate them, right? So we need to be looking for strong signatures, for strong signals, if we want to have tools that are good at the population level. But I think also the field has advanced a lot, and this is just one way to deal with these variabilities, which is in the post-processing setting of harmonizing the measurements extracted based on known and unknown what we call batch effects, kind of acquisition kind of variability. And our groups and others have done a lot of work in this space, looking at methods, adapting methods, for example, that originally were proposed in genomic data harmonization to the radiomics setting, and how do we take into consideration the different protocol parameters? How do we even look statistically for batch effects that we may not even know? There's a whole field right now in machine learning and deep learning sort of domain adaptation that deals with similar problem. There's also a lot of approaches that address harmonization of the scans themselves. Although that, in my view, is a little bit more computationally expensive. And when you start having data sets with thousands and thousands of 3-dimensional, 4-dimensional scans, in my view, it's a little bit more computationally intense to try to look at the harmonization of the scans first. So there are ways, in my view, that we can address this, and I don't see it as an issue that kind of should impede progress scientific progress in this area, but rather like an array of tools that we could use to address this problem on a domain specific and application specific. And as I said, deep learning, obviously, and AI is a major area here to be considered. It can be used both with the original scans. Again, things get a little more complicated once we start getting into 3D scans, and when we start looking at 3D, 4D scans, and the entire scan as an input, as in this setting where we're looking to characterize the entire breast parenchyma. It could also be used as a way to combine this kind of multiparametric radiomic information. Encoders can be very valuable in this setting. But we also have a lot of advances now in the area of sort of vision transformers and ideally vision foundational models. I think that can be used in this space. So it's an area that I think will be very exciting. It can help us even improve the analysis of the data. That said, I'm always a fan of simple is better. And we have to think a little bit about when there's truly a need and a benefit to scale and make the analysis more complex as it requires more data to result into reliable models, but also more computing resources, which we know are getting more and more difficult to have, abundantly. So that's something always to keep in mind, but I do think there's a lot of potential in this thing, and we're already start seeing some applications coming out that seem to be very promising. And so switching gears a little bit, I'll touch a little bit based on the prognostic assessment, similar concepts, computationally, but here instead of looking at the whole breast, for example, we're looking at the individual tumors. And we're particularly looking at characterizing the phenomenon of intertumor heterogeneity, which has been getting a lot of attention as an important prognostic and predictive marker that is difficult to assess clinically. A lot of the biopsy sort of samples are based on a very small tissue sample, then they don't capture the entire tumor volume and its heterogeneity. And on the other hand, a lot of sort of liquid biopsy sort of attempts, which are very useful, don't have that sort of spatial domain component, and they also have less sensitivity and even less specificity. We have single cell analysis and spatial transcriptomics, which are very useful, but again, very tough and very expensive to apply on a whole tumor scale. So imaging, I think, offers a unique opportunity to capture that heterogeneity in vivo and non-invasively, although at a smaller sort of, not at a cellular scale, but still I think has a lot of value, especially if we can combine with other biomarkers. And so, for example, in breast cancer, where do we care about that? Because the determination of what therapy may have the most benefit for each patient is not a simple decision. It weighs several factors, as tumor pathology and pathologic characteristics, and more recently also molecular profiling characteristics that have come to be available in the clinic. And so it's a decision that takes multiple factors into play, especially factors looking at characterizing this phenomenon of tumor heterogeneity. And so, for example, here you can see a pictorial sort of depiction of tumor heterogeneity and how it may evolve in the tissue. You can see that, if you were taking, for example, a biopsy at the blue area, you may have very different information about what this tumor is made of, and if you're taking a biopsy at the red area or the orange area. And that's a limitation that, it's important to address. And maybe you may say in some cancers like breast, it's not as a big deal to stick a needle in a couple of more places and get that heterogeneity. But if you're thinking about like brain or lung, the biopsy itself may kill the patient. So it's not like you're starting to like randomly sample the tumor just to get a sense of heterogeneity. So imaging can be a big ally, I think, in this context. And our studies and others have shown that there's a lot of that. From a computational perspective, again, a very interesting problems to address. And I know there's a lot of work that's come out of Yale, and in this context is in terms of like automating segmentation approaches, and which is a very important part of this characterization to get the periphery and the perimeter of the tumor accurately, both in terms of characterizing the morphology, but also getting accurate volumetric measures. And then, looking also, for example, at dynamic imaging, there's a lot of information we can extract from the internal part of the tumor, looking at the uptake of the contrast agent, which we know is related to the angiogenesis of the tumor. You can see, for example, here, even then within one tumor, you have very different profiles of the uptake of the contrast agent. Some areas have a very quick uptake of the contrast agent. Some areas have a very slow uptake of the contrast agent. And so the conventional sort of hotspot approaches of just capturing a small area may be not enough to get us the information about heterogeneity and how that may implicate treatment and response to therapies. So where we are right now as a field, I think we have a lot of methods that are really good at kind of capturing that spatial heterogeneity of tumors from radiologic imaging, very, accurately in terms of from a computational perspective. But we're far from really understanding what that means and having studies that really map that imaging kind of phenotypic heterogeneity with the underlying molecular and biological makeup of the tumor. If we were able to do that, then we could have a true assay of human heterogeneity based on sort of computational approaches and imaging. Some of the studies so far, have also looked into functional heterogeneity. For example, in FDG PET here, you can see sort of computational approaches. We develop an approach. I'm not going to go into mathematical details, but basically summarizing the connectivity curves within a tumor and trying to see different parts of the tumor that may have different or similar characteristics. And then how do we extract information from these different parts, assuming that there's some kind of different biological significance, and that if that has value for prognostic assessment. And for example, here in a study we recently published in the European Journal of Nuclear Medicine and Molecular Imaging, we saw that these type of approaches, we were able to extract additional prognostic information to the conventional sort of histopathologic measurements. And again, looking again at these heat maps, we can apply similar principle as the one that I showed previously for the overall breast parenchyma, looking at the tumor characteristics and looking at the heterogeneity of the tumors. And this study was actually published, 10 years ago at this point. It was one of the first to look at whether or not we can identify intrinsic phenotypes of tumor heterogeneity and what was the association with surrogate outcomes of prognosis. For example, the genetic molecular profiling score. And for example, I don't know if you can see here if the resolution is sufficient, but what we saw even at that point was that in these different groups that we defined based on imaging and radiomic features for tumor heterogeneity, there were some tumors that when correlated with genomic profiling assay scores, they were either at low or medium risk of recurrence, which we now know that these patients do not need, for example, adjuvant chemotherapy in their regimen. Whereas there were other tumors that have distinct characteristics and higher heterogeneity that had a mix of tumors at low, medium, and high molecular characteristics, which we now know would benefit from adjuvant chemotherapy. So again, there's information in imaging data which can be useful in the prognostic and predictive setting. And one of the reasons that, I think this is a very low-hanging fruit for the community to leverage is because all these imaging scans are already done for routine clinical use, for staging, for detection, for biopsy guidance. It's not like we're doing any imaging just for the purpose of the sort of biomarkers. And all this data is sitting, in the PACS, probably never to be looked at by anyone ever again. And there's all this information that we could be extracting that could bring value into the diagnostic and prognostic setting that we're currently not leveraging. See, for example, here, example of 2 breast tumors. If you were going by the RECIST criteria that measure the longest diameter, right, not the volume, you may find that those would be very similar, right? But then if you look at the volume, volume alone, maybe you'll see some differences. But the morphology of the tumor, and especially the internal part of the tumor, are way different. And in fact, the tumor on the right-hand side seems to have more rapid uptake of the contrast agent throughout the entire tumor volume, seems to be at a high risk of recurrence based on molecular profiling, versus the tumor on the left seems to be at a low risk of recurrence based on. And again, here, I think the holy grail is to look at correlating with recurrence, free survival, and overall survivor outcomes. These studies are much more difficult to do, especially in breast cancer, because it takes almost 10 years to fully track recurrence and overall survival outcomes. And by that time, the imaging modalities are evolving, so it's a little bit of a catch-22. But again, we see here when we correlate with true outcomes that adding the information from imaging data that is kind of readily available in the clinical sort of archive, can add prognostic information to conventional histopathologic criteria. So how does that heterogeneity look like? Again, you can see here 3 examples of breast tumors, low heterogeneity, medium heterogeneity, and high heterogeneity. You can see it visually here how the heterogeneity manifests. And you can see that these tumors are definitely a much more aggressive tumor based on known criteria as a tumor negative, a node positive breast cancer versus the less heterogeneous tumor. Looking at sort of how this imaging sort of phenotypic tumor heterogeneity correlates with known sort of histopathologic characteristics of heterogeneity. For example, you can see here that tumors that tend to have low heterogeneity with the radiologic approaches can be more well differentiated, which makes sense. Whereas tumors that tend to have more medium and high heterogeneity from radiomic approaches are also poorly differentiated, which makes sense prognostic. Looking again here, tumors that are low heterogeneity tend to have lower mitotic stage versus tumors that tend to have higher imaging heterogeneity and have higher mitotic stage, which again makes sense biologically, with a caveat that again, we're not comparing apples to apples, we're comparing the tissue sample from biopsy versus the whole tumor assessment. And last but not least, during therapy assessment, we can take that information and apply registration techniques, which your groups here have been some of the pioneering groups in this area developing registration methods to look at how that heterogeneity changes over time, especially early in the course of therapy. When we see an increase in heterogeneity, that may be an indicator of developing de novo resistance in the therapy, and that could be an indication that the patient maybe needs to move to a different type of therapy, and it's not a good responder for the specific one. Obviously, sort of the registration process can itself give rise to additional features to evaluate, deformation fields and other information that we can get more refined descriptors for the morphological changes of the tumor and the structural morphological changes of the tumor, in addition to the information on tumor heterogeneity, which we can also now observe over time at a very, very fine level. One study that has been analyzed by several groups are the I-SPY1 and I-SPY2 now studies for breast cancer, which is a longitudinal assessment with breast MRI as predictors of response to neoadjuvant chemotherapy for breast cancer, with outcomes including both pathological complete response and recurrence-free survival. And that's an area where our groups and others have applied their algorithms to look at how different approaches can get us more predictive information, looking at baseline features such as the functional tumor volume, aggregate type of features, and then looking longitudinal voxel-wise features with registration. And you can see as we sort of improve the computational approach to the problem that the ability to predict the outcomes improve over time, which is again an important predictor. And I always like to look, at this sort of visual example. So what does this practically mean? Why do we care about this? So for example, in the context of the I-SPY1 study, the functional tumor volume, measuring volume from MRI, was deemed to be the measurement that can be used to predict who's responding and who should go to different types of therapy. So if you take the patients of that study and you split them based on the functional tumor volume, which we did for this one, you can see like a very nice separation, basically recreating the primary endpoint of the trial and so forth. But when you start then taking into consideration the heterogeneity of the tumor, which is something that just the volume cannot fully capture, and you overlay this biomarker as a way to further risk stratify women, we observe the following: that the women who were predicted to do well, really much separation here. You can see the dotted line, orange line, and the solid line. But the women who were predicted to do worse separated, and in fact, one line completely almost bundled with the women who were predicted to do well, and then the other line became even worse. So what this may mean is that this information on tumor heterogeneity may help us distinguish early on in the treatment which women are predicted to do well, or which women are going to do even worse, and can add the information from the functional tumor volume and into further maybe identifying women who may be otherwise overtreated. Breast cancer right now has, in general, relatively good therapy outcomes as compared to other types of cancers. But one of the debate that has been arising in this field is we have these good outcomes because we're overtreating a lot of women. And so a big debate right now in the context of breast cancer therapy is de-escalating treatment, not necessarily escalating treatment. And so these approaches can help us in both ways, identify, individuals who need more therapy, but also, and perhaps equally importantly, identify individuals who need less. And here's another area where imaging, conventional imaging, can be very useful. In a similar context, we can do similar approaches, for example, for lung cancer, look at radiomic phenotyping of lung cancer tumors. We can think of these signatures as markers of response to targeted therapy and immunotherapy, again, similar pipelines for the analysis. Some of the work we've done here is to see if we can integrate with other biomarkers, such as liquid biopsy, which is used a lot in the context of lung cancer characterization and therapy sort of determination and identifying certain mutations that, for example, EGFR mutations that may be more ideal candidates for TKI therapies, and look again at the example of like combining radiomic measurements with liquid biopsy data and the ability to further improve the prediction of Similarly, in the immunotherapy setting, again, extracting this type of information, combining with current standard of prognostic markers, PD-L1 expression, ECO scores, and so forth, and seeing whether or not these markers can help us distinguish patients who are more likely to respond to immunotherapy. And one of the exciting, I think, aspects in these times is that you don't have to be a computer scientist or a programmer to do a lot of these things. Our groups and others have developed tools that you can download freely from online. You don't have to program yourself anything, but you can load in all kinds of different data sets, from neuroimaging data sets, breast data sets, lung data sets, and extract these features seamlessly and even build some preliminary models and do some preliminary analysis. And so a lot of these tools provide both kind of some of the more basic sort of computational functional capabilities, as well as modeling capabilities, which make them very attractive also for clinical applications. And so where the field, I think, stands at this point is like we have a lot of kind of maybe single institutions, maybe a couple of institutions, smaller studies, showing feasibility, showing promise, generating a lot of excitement, but we don't yet have much of these tools translated in the clinical setting, which is what I think collectively we need to consider as a field on how to move the science forward. If it can't help people, like, why are we doing it? Right? And so coming together in multi-institutional studies, coming together in consortia, I think the brain imaging in the neuro-oncology community has done that much better than other domains, establishing this large consortia and leveraging data set for not only comparing algorithms, but developing sort of models at scale. Obviously, approaches such as federated learning can be very helpful here in trying to bring data sets and investigators together and trying to scale these studies and ultimately achieve translation to the clinic. A lot of non-sort of traditionally computational cooperative groups are now also increasingly becoming interesting in these activities. So, for example, in the ECO background, there has been a radiomics working group for a while. There's now also a data science committee actively looking in a lot of these research questions in both retrospective data sets from clinical trials, but also in the design of prospective oncology trials. And ultimately, I think where's a lot of excitement, I think the future of this field is in the combination of these multimodal biomarkers from imaging, from electronic and medical health record data, from pathology, digital pathology, molecular profiling, into personalized, not only cancer care, but across diseases. I think this is a theme that we will increasingly see evolving. And I think there's a lot of space both for development of novel methodologies with conventional sort of computational approaches, AI approaches, but also a breadth of applications that can be considered in the space. And a little bit of a shameless plug of some of the stuff we're doing in Columbia on this area. This is a new center that we're sort of spearheading there, exactly to create an ecosystem of imaging scientists, but also non-imaging scientists and physician scientists who can come together and push the scientific frontier in this space. The Center for Innovation in Imaging, Biomarkers, and Integrated Diagnostics. We're leveraging artificial intelligence for personalized medicine with a strong focus on cancer, neuroimaging, cardiology, informatics, outcomes, digital pathology. These are some areas of focus with very active sort of faculty recruitment at this point, both in basic scientists and physician scientists, and hope to formally launch the center early in the fall. Would love to discuss about sort of opportunities to work together. We're sort of nearby, only a short train ride away. So I'd love to hear more about all the exciting stuff happening at Yale now, as for many, many decades, and would love to find ways to synergize and build on these initiatives moving forward. So with that, I'd like to thank you for having me here today. You know, one of the most fun things about doing this type of work is this work that truly requires a multidisciplinary environment. This is not the kind of work you just do by yourself and publish your paper and then you're done. I often say I hang out more with non-computer scientists than computer scientists. You know, it's work that is a very sort of integral to oncology, systems biology, population science, even primary care, radiology, obviously, biostatistics, epidemiology, and there's an exciting ecosystem of collaborators that personally make my day every day. So thank you for having me here. I'm excited to learn more about the latest and greatest going on here, and I'm happy to take any questions. So thank you. Yes.
Thank you for a nice talk. Really enjoyed having you. So I've always been amused with the radiology community's fascination with radiomics and the feature vectors. I mean, to me, it's sort of a random sampling of the greatest hits of pattern recognition from the 1970s and 80s. And a lot of these measures are statistically dependent. So, I mean, they measure basically the same thing. There's only 3 or who knows what the number is, but maybe 4 or 5 things about intensity variance, mean, directionality.
Right.
So when you start to make heat maps of them and sort of try to infer things, you know, information from that, I think it's a little different than the gene heat maps where you've got, in theory, independent information on the rows. So, I mean, the clustering of information, it's sort of, there's so much statistical interdependence that it doesn't feel like like even when you look at, they cluster into different things, you can see them vertically.
Yeah.
And I just, do you really, I don't know what the question is, except do we really need them all? I don't know what, I mean, if you could rotate it into a, you know, something like a principal component set of finite things, I don't think you need hundreds, you might need 5, I don't know.
No, that's a good point. And that's, you can see sometimes the PCs perform as well. Well, first of all, go back to your questions. I think with the genetics and RNA sequencing, there are associations there as well. And often you'll see, you know, they run, you know, studies to find some signal, and from like thousands of like tens of, they only have like a very few hits here and there after very aggressive kind of p-value corrections there as well. Right, so there is some correlation there. There is some noise there, definitely. I definitely see your point of how this is even more exacerbated on imaging data. But I do think there's some value in this sort of visual interpretation of these measurements, especially in a clinical context. You know, we know that sort of the black box approach is less and less likely to move forward clinically. And so while we as computational scientists very much enjoy having like PCs that reduce the information and does the job equally well, you know, PCs don't have the same kind of interpretation that's something that's visual that you can show and say, hey, this is a very heterogeneous tumor. You can see how that looks red in the heat map, and then look at it also in the scan, and it's obviously more heterogeneous. Start making some connections that, you know, generate that trust in the black box to move it forward clinically. So personally, I think there's definitely value in that space. But your point about noise is very well taken. I think, you know, we can get more sophisticated in reducing that information, but also in some ways, isn't that kind of what CNNs do at a higher scale? And then they end up being they end up overfitting.
Well, that's another
radically.
black box.
So like basically what CNNs do, right? That's why unless you have like huge data sets, they overfit like crazy, right? Because they do radiomics on steroid at so many levels, right? And there is a lot of noise and correlation, and even on those convolutional filters that they're.
Right, so if you did, if not you, whoever, all of us did more intelligent, I don't know what, reduction, that maybe we get out smarter things rather than.
Or more simple, you know, we tend to think that more complicated is more sophisticated is better, but I don't know if that's always the case. But your point about the PCs is very well taken. I just think there's something to be appreciated, also the ability to interpret a little bit these measurements and visually appreciate what they actually are capturing. But you can also do PCs in the clusters and then just take the PCs. and move forward with those. Yes.
Just to follow on. So what type of let's assume for the sake of argument, the more complicated methods give you higher accuracy, less explanation. Simpler methods, lower accuracy, much higher explanation. What performance hit for explanation are you willing to take?
So this is an excellent question, and this is one of the reasons when I decided to do this research, why I decided to do this research, like why I ended up going in breast cancer risk assessment and on something else. So at that time, at least, and even now, the state-of-the-art model for breast cancer risk assessment 15 years ago, whatever, was the Yale model, right? So, and in epidemiology, there are two metrics, right? There's the calibration of the model, and there's the discriminatory accuracy of it, which is closer to what we call AUCs, and the calibration is the expected to observe ratio. So these models had very good calibration, but their discriminatory accuracy, their AUCs, were on the order of 0.52. And those were the models that the doctors were using in the clinic to decide who was going to get chemoprevention. And chemoprevention, if I were to be a high-risk woman at a little bit more than 40 years old taking chemoprevention, that means I would go into early menopause. I would have a risk of getting cataract. My blood pressure would increase, and a whole bunch of stuff that are not ideal for a model that only has accuracy at the individual level of 0.52. And then I was coming as a computer scientist, right, where if we had any model that had accuracy of 0.52, we couldn't send it to the most basic conference ever, right? You couldn't even present it to your advisor. They would tell you just go back and do the whole thing, and you have to dare come up here until this goes up. So at that point, I would like, we'll take anything that's better. And even now, the most complex kind of clinical models, like the Tara-Cusick model that takes into consideration complex family history, they're like in the 60s, the AUC. Right? So we are way in the clinical setting, we are way back where we could be given the advances we have in the computational space. The same, for example, in therapy response evaluation, right? RESIST. People are still doing RESIST. RESIST is done by somebody sitting there visually clicking the scan, right? Those are some of the examples as a grad student coming from a computer science department that kind of blew my mind and say, I think this is where we need a little help, right? Trying to determine who should get what therapy, but such a very subjective assessment.
One-dimensional.
Right, yes, right.
One-dimensional.
One-dimensional, visual, like, right? Totally, like, blows my mind. So, but to answer your question, I think anything we get that's better, it's better. But I'm also not sure that more complex computationally is better. It's maybe better in smaller studies, but I think there's a lot of overfitting that doesn't replicate when you go into a larger data set. Again, because you have that inherently so many degrees of freedom statistically and such a complex, input variables at the end of the day that make the problem more difficult. So I'm not sure that complex is always better, although we do have a tendency to think that complex is better, but I'm not sure that's the case. Yes.
So intuitively, if the imaging has higher noise or the reconstruction with different correlation, then the feature could change. Just curious from your
Yes.
experience, how sensitive are the features, radiomic features?
Features
Depends
are sensitive.
on those noise level and the correlations.
So from studies, some features tend to be more sensitive, some types of features tend to be less sensitive. But I think at the end of the day, a lot of these sort of post-processing, sort of post-hoc harmonization techniques do a pretty good job at, reducing the effect of the noise and creating reasonably valuable. So it's not necessarily something that keeps me up at night, but something to definitely be aware of and make sure there's like a rigorous way to address it.
So thank you very much.
Thank
This
you,
was
Adam.
great.
John, there might be a couple of chat.
Well, what is this next day?
Chats, let's see, those are one. There's Samiko.
Anonymous,
CME stuff. No, we're good. Yeah, we're good.
so staying on it to monitor the tab. All right, thank you.